Welcome to another episode of Clot Conversations from Thrombosis Canada. I'm David Airdrie, and I'm here at the ISTH 2025 meeting in Washington, D.C. with my co-hosts Maha Othman and Jamil Abdulrahman, along with our guest today, Tzu-Fei Wang. And I'm going to pass it over to Maha.
Thank you, David. Well, we're delighted to have Dr. Tzu-Fei Wang today with us at the ISTH 2025. And I see, Dr. Wang, that you have been very busy at this conference between oral sessions, posters, moderated posters on cancer-associated thrombosis on different things and anticoagulation. So why don't you give us some synopsis and highlights of what you've presented this conference?
Sure. Thank you, Maha, and thank you, Jamel. It's a pleasure to be here, and thank you for listening in. So yeah, it's kind of a teamwork that we're able to present some of our work that's been really ongoing for some of them are many years. So the first two are really abstract. Our goal is to investigate whether drug-drug interaction is clinically relevant for patients with prostate cancer on concurrent anti-cancer prostate cancer hormonal therapy that potentially can interact with DOAC. So as we know, the right oral anticoagulant has been commonly or more increasingly used in the cancer population. But DOAC is metabolized through two different pathways, the CYP3A4 and the PGP pathway, the P-glycoprotein. So there's always been a concern if there's a concurrent use with strong inhibitor or inducer with DOAC can cause a increased risk of bleeding with inhibitor and increased risk of thrombosis with inducer. But a lot of these data are really purely based on pharmacokinetic interaction that's in vitro. So we really have very little clinical relevance data. So what we did is we used two province population-based database. From Ontario would be in ICS. From Alberta would be from Alberta Health Services. So we look at adult patient in Ontario is over the age of 66, and in Alberta is over the age of 18. And these are patients with prostate cancer who are taking. We actually have two cohorts, so that's two different abstracts. So the inhibitor cohort is the abiraterone that's being reported to be an inhibitor for both CYP and PGP. So they are our comparisons. We compare patients who are on abiraterone plus DOAC concurrently to abiraterone with any other anticoagulants that includes lomogaparin and warfarin, and we look at and then we follow them and we look at their outcome of bleeding and thrombosis. And this is the outcome is identified by ICD code, as this is a population-based database. And then on the other side, we have another abstract enhancer that's inducer, I should say. That's the enzalutamide and apalutamide is a prostate cancer drug. Again, concurrent with DOAC and compared to non-DOAC anticoagulant. So we also look at the same outcome, thrombosis and bleeding, but for inducer abstract, thrombosis will be the more outcome of interest, as that's what's predicted in the pharmacokinetic data. So really the bottom line is what we found is we actually did not find any significant difference when we compare for both inhibitor and inducer cohort to compare DOAC versus non-DOAC group in really any of the outcome, bleeding, or we look at AVTE outcome, we look at arterial thrombosis outcome, we look at major bleeding, and we look at any bleeding. They really have no significant difference. And what we also found very reassuring is the outcome rate is quite consistent across the province compared to Ontario versus Alberta. So we're hoping that this is really the largest cohort that we are aware of, because for Ontario cohort is about a little bit more than 1,000 patients, and for Alberta cohort is about 500. So for either inhibitor and inducer cohort, so this is really the largest cohort that we know in the literature. So we're hoping this can provide some clinical relevant data for the clinician when and it really seems to me that prescribing this anticoagulant may not be as concerning as one would think. So that's the drug interaction part. And the second part is really we're reporting the result of the WAVE study, which has been ongoing for quite some time. The WAVE study, I think many of the Canadian Center have been participating, so you might know. It's a multi-center prospective cohort study of using weight-adjusted dalteparin without the typical dose capping of 18,000 to inpatient with acute cancer-related thrombosis requiring anticoagulant. So the reason we do that is because by the monograph of dalteparin, we're supposed to, or at least not supposed to, but at least the monograph tells you to to cap the dose at 18,000. But that means that as a standard dose of dalteparin, 200 units per kilo, anyone over the 90 kilogram will be getting the exact same dose. However, there's some concern that this dose capping may lead to under anticoagulation in the obese population and could increase risk of thrombosis. And many Canadian practices already not really capping the dose. But there's really no study out there to evaluate the outcome on non-dose capping. So that's the idea of this study. So the study is open for recruitment from 2018 to November 2023. And a total of 92 patients was enrolled, but one patient was excluded after enrollment due to ineligibility. So 91 patients was included in our analysis. This is lower than the initial intent of 150 patients. The study has to be terminated early because of very low recruitment, unfortunately, because of many reasons, including COVID pandemic and increasing, prevalence of using DOAC in this population. But we're able to analyze the 91 patient data, which I think is still quite helpful. What we found is we had three. Our primary outcome is major bleeding defined by ISTH criteria at 30 days. We did have 3 patients had a major bleeding event that correlates to the cumulative incidence of 5.3% at 30 days. That's after accounting into death as competing risk. We only have 1 patient with recurrent VTE, so the cumulative incidence is 1.2%. So overall, we feel that this demonstrated this dose-adjusted dalteparin is generally safe and effective and could have implications in guiding future kind of dose prescription, dalteparin prescription in this obese population.
Thank you, Tzu-Fei. So can I ask, with the dalteparin, was that administered one dose at a time, or was that split into BID dosing?
Oh, yeah. Great point. So you can do either. So we do have a table to guide, depending on the patient's weight to guide the dose. And usually you round, to the closest syringe size. And you can do either once a day or altogether for the full dose or twice a day. So the provider can decide. I would say that as the dose, as you know, as the dose go up, most we have about 60%. The most provider will split into BID dosing, so about 60% of the patient get BID and the rest gets once.
Thank you. And do you think we can extrapolate this to the other low molecular heparins like enoxaparin and tinzaparin, or do you think this is dalteparin specific?
Yeah, very good question. I guess to be by the book, we only study dalteparin, so certainly our data really only apply to dalteparin. But certainly people might, I know clinically we're pretty much using it with other DOAC too, including tinzaparin. As an outpatient, we don't use, in my experience, we don't use enoxaparin as much because it's by BID dosing. So just to help the patient out, we usually try to change to once daily dosing. But, you can make the argument that when the weight is so high and you have to continue to go up on the dose, it's twice daily anyway. So I would say that our study really only studied dalteparin, so probably shouldn't be extrapolated. But clinically, I've seen that is we do that for other low heparins.
Right, thank you. That's very helpful. I'm just going to pass it over to Maha.
I was just going to ask, are there any manuscripts in the works or have been published already to guide our audience here?
Thank you. Yeah, both manuscripts written actually is in the WAVE is probably closer, but it's just in the process of getting co-authors to review and fine tune it and hopefully improve it. And so I'm hoping that both can be submitted soon.
Perfect. Thanks so much for your time.
Thank you all for your time today, and thank you, Tzu-Fei, for the insights on your presentations at ISTH 2025. And thank you to our audience for listening to Clot Conversations. We appreciate your support. Don't forget to check out our website, thrombosiscanada.ca, for materials and resources to help your practice and your patients. Look forward to sharing with you the any links to the papers when they are published. And thank you all for tuning in to Clot Conversations once again.